So good evening, everyone. We have Dr. Nitin Ghonge, eminent radiologist with us. Will be taking us a radiology for the nephrologists. He's agreed to give us time out of his busy schedule. So at the onset, we thank you so much, sir. And it's all yours, sir.
Thank you for the invitation. And so I hope the the attendees for this talk are mainly DNB PG students or PG students in nephrology.
Yes, sir.
Maybe,
DNB and some DM also, sir.
okay. So, uh, so as radiology is an important uh, branch of medicine and it applies to all the disciplines right from uh, head to toe. So in DNB and DM nephrology also there are a lot of uh, in right from appearing for exams as well as for the routine clinical practice. You need to understand the basic concepts in radiology. And this presentation is all about the basic concepts only, and I will talk about few basic points, basic across the modalities, but how it affects the clinical nephrology practice, basic concepts, and I will also touch upon few basic points about the cutting edge imaging options, I mean imaging tools also, which are I'm not going to go into more details of them, but as a nephrologist or as a budding radiologist, as a budding nephrologist, you need to know about these cutting edge modalities as well. So for a nephrologist, the radiology is required for a wide range of clinical settings, right from calculous disease to congenital and developmental lesions to infective and inflammatory conditions to pre and post treatment imaging, evaluation of renal tumors, renovascular hypertension, renal transplant, and a lot of miscellaneous settings which cannot be listed in a single slide. So the nephrologist should be able to evaluate the plain radiograph in a sensible manner, as I am going to just describe in this example. So we can see a supine erect radiograph of abdomen, which can be acquired in supine as well as erect position. So from nephrology point of view, you need to be clearly looking at the renal margins, as we can see here on the both sides. The margins of the kidneys may be seen to varying extent depending on the retroperitoneal fat. The complete margin may or may not be seen, but here you can make out the margin significantly, mainly along the lower polar region of the right kidney, but not very clear on the left side. So this can happen, and then always look for the abnormal. Radiograph is all about density, so you need to be looking for hyper bright areas or opaque areas or lucent areas. If there is any lucent area, then it can be fat or air. If it is hyper or bright area, then it can be because of a stone or any abnormal opacity. So looking at the kidneys on both sides, and then look at the ureter. The course of the ureter is important, as we can see the transverse process on both sides. So this is the course of ureter, and at the level of pelvis, the ureter goes laterally and then it turns medially to join the vesico-ureteric junction. So this is the KUB region should be clearly seen for any abnormal density on a radiograph of abdomen. Then the chest radiograph is very important for the nephrologist from multiple point from multiple point of view, as we need to look at the lung fields for the pulmonary edema if there is any cephalization. So these are the blood vessels which are more prominently seen in the lower zones, which is a normal case in a standing position. So you should be able to see that the vascular markings are more prominent in the lower pole, which is normal, and less prominent in the upper pole. But if there is a equal distribution, like more vessels in the upper pole as much as the lower lobe, then it is called cephalization of the pulmonary blood flow, which is a important sign of pulmonary edema or CCF. So pulmonary edema is something important which should be looked for from nephrology point of view. And then again, for any opacity, pleural effusion, as a sign, or pericardial effusion where you will see cardiomegaly, and then looking for abnormal opacities like pneumonitis or cavitation in the lung fields. So therefore, it is important to look at the lung fields very carefully, look at the postophrenic angle, cardiophrenic angle for effusion or lesions or pneumonitis, and always compare the opacities on both sides. At the same time, the cardiac margins should not occupy more than one third of the total outside to outside dimension. As we can see, this is a normal alignment of the cardiac margin. So this is an example of a radiograph of abdomen where we can see the cardiac opacity very clearly, but on the left side we can see a increased density. Now you can see the increased density overlying the lower calyceal system of the kidney because of the renal calyceal calculus. So when there is a calculus, it is important to get a CT scan done to look for the obstructive changes, look for the adjoining structures, look for the inflammatory changes, look for the density of the calculus, and accordingly, if it is very dense, then lithotripsy may not be possible. If it is less dense, then the lithotripsy is possible in this calculi. And then at the same time look at the surrounding ureteric wall. The ureteric wall, if it is thickened, that means the calculus is really impacted and it is unlikely to pass of its own. So therefore you can see the ureteric inflammation thickening, and perinephric inflammation also is seen in this particular image. There is something called as dual energy CT, which is in a better position to decide and define the stone composition, whether it is a uh, uh, urate calculus, uric acid calculus, or oxalate calculus. So these points can be seen and evaluated based on the dual energy CT, which is a new technology now. So interpretation about IVP is important from renal point of view. Though IVP is now increasingly being replaced by CT urography, but the basic concepts remains the same. So you can see this is the renal margin, and initially as soon as the IV contrast is given, the nephrographic phase is seen on both sides. So renal parenchyma, the contrast traverses the renal tubules, and you can see opacification of the renal parenchyma, that is nephrographic phase. But the moment it is excreted in the urinary system, the calyceal system, and the pelvis and ureter, then this is what is called as a pylographic phase. So this is a excretory or pylographic phase of IVP on both sides. You can see the ureter and then the urinary bladder in the late phase. So always look at the uh, C-shaped calyceal system. This is normal. This is the normal renal pelvis. This is the normal interrenal distance, which should, and this is the normal axis of the kidney. But in this example, you can see there is widening of the distance between the two kidneys, altered axis, mass effect is seen over the calyceal system. So this is because of the only two possibilities: lesion which is occupying the place between the two kidneys. Either it can be aortic aneurysm or it can be lymph nodal enlargement, as we can see in this example. This is another example. I told you the ureter should traverse this this transfer processes like this, but here you can see undue medial position, medialization of the ureter at lower lumbar level because of the retroperitoneal fibrosis. So this sign is called mid-in waist sign. So this looks like a constriction or medialization of the ureter on both sides. So this is because of the retroperitoneal fibrosis. So the course of ureter is very, very important and should be seen on CT or conventional IVP. So the conventional IVP is now replaced by CT urography, where we have a additional uh, phase because of the higher attenuation, higher signal intensity, higher spatial resolution of CT scanners. On IVP, you can only see the nephrographic phase and pylographic phase. You will see the contrast in the tubules, you will see the renal parenchyma, and then you will see the contrast in the renal pelvis in the routine IVP or nephrographic or pylographic phase. But with CT scan, you can acquire a corticomedullary phase, which is even before the nephrographic phase. So time wise, this is say around 10 to 15 seconds. You will see the nephrographic phase in a corticomedullary phase, and then you will see nephrographic phase after 60 seconds of contrast injection and pylographic phase after 5 minutes of contrast injection. So this is the corticomedullary phase where you can see the contrast mainly in the cortex, and medulla is all dark. With increasing opacification, then the corticomedullary differentiation is attenuated, and you can see contrast in the medulla as well. So this is nephrographic phase. So this three phases should be clear, and the CT urography acquires all these phases, and accordingly the diagnosis is made when it comes to renal pathology. So similarly, you can see this another example of a CT urography reconstructed image, and this is a conventional urography where you can see the uh, complete KUB and ureter all along its length. So this is an image. This is a conventional CT urography image in an excretory phase where you can see the kidney on both sides, and then you can see the contrast in the pelvic alyssal system and ureter, but no vessels are seen. This is an image which shows a modification of a CT urography technique where you are seeing the kidneys, the contrast in the ureter, and the contrast in the bladder, and at the same time you are seeing the contrast in the aorta as well as the renal artery and faint opacification of the renal vein also. So this is basically something called a split bolus method where you can give two different bolus of contrast before the scan acquisition on CT table. So the earlier bolus will is already excreted in the urinary system and is opacifying the bladder and the ureter, while the second bolus, the second phase of the contrast is opacifying the kidney, renal vessels and the aorta, as we can see here. So this is a single image because CT leads to lot of radiation. So it is important as a clinician, you need to be aware about the concept of radiation safety with CT because multiple phases increases the radiation multiple times. So it is always good to minimize the number of acquisitions in a CT scan. So accordingly, if required, plain scan is done. If required, only nephrographic phase and pyrographic phase is done. But if you are concerned about the vascular structures also, so this particular method helps to minimize the number of scan acquisitions which are to be done in a for a particular scan. Like for many studies, if it is not required, we trying to abolish the plain scan also. So depending on the clinical indication, we can reduce the number of acquisitions so as to reduce the number of uh, phases, and that will reduce the amount of radiation. So that is one important drawback with CT because of the radiation, which is not there with MRI. So another important thing which as a nephrologist you should know is if for some reason contrast cannot be given and you want to evaluate a particular abnormality and only plain CT is to be done, something like renal abscess, something like pyelonephritis, or abnormality related to the renal parenchyma, then it is always better to advise MRI. Why? Because of two reasons. MRI has a higher soft tissue resolution. MRI is able to pick up pyelonephritis or parenchymal lesions or even abscess without need for IV contrast as compared to CT. In CT, without IV contrast, it becomes difficult to diagnose abscess or pyelonephritis. So that is one important thing. And second thing is that contrast safety of MRI contrast is much more as compared to CT contrast. So this is important point that if the creatinine values are borderline something around 1.2, 1.4 of serum creatinine, then there is something known as isoosmolar contrast which can be given for CT imaging. But if the risk is more and the creatinine value is high, maybe 1.5, 1.6, then depending on the eGFR values, we can decide to convert the study from CT study to MRI study because MRI contrast safety is higher as compared to CT contrast. Then coming to the filling defects in IUP, you can see this normal pelvic alysis system is always C-shaped like this, C-shaped like this, and here you can see the irregular appearance. This is the calculus which casts shadow like this. It depends on the ultrasound technical parameters. At times, you can see the calculus is casting this Doppler signal also because of the reverberation artifact. So this Doppler also can help in better diagnosis of renal calculus. Very important that the diagnosis of ultrasound ultrasound diagnosis or calculus is very, very observer dependent. Like chelicial calculi 4 mm, 5 mm may be wrongly measured or maybe missed on ultrasound. So it is important for the observer to be very objective in terms of technical settings to decide whether the calculus is really there or it is an artificial ecogenicity because of the technical factors, because of the multiple interfaces. There are a lot of physics involved in deciding whether a small ecogenic area is a stone or a artifact. So this is therefore it is important to understand that whatever is reported on ultrasound as small calculi may or may not be calculus, and it depends on the technical expertise of the person who is doing ultrasound. Then looking at the filling defect in the urinary bladder, irregular margins, cauliflower shaped appearance, this is stipple sign because of PCC. This is another example. You can see the contrast on the left side is excreted in the kidney in the proximal ureter, but on the right side no excretion. And this is a dense nephrogram. This is persistent dense nephrogram because of the distal obstruction on the right side. Dense persistent nephrogram. Whenever there is contrast in the ureter, it should be seen some segment, then no opacification. So peristalsis leads to non-continuous opacification of the ureter. But if you see something like this, a continuous column is a sign of some obstruction at the VU junction. So this is important. And then look at the pelvic system on the left side. Normal appearance, normal orientation, but here it is displaced because of the extrinsic compression of the duplex renal moiety on the right side. So this is drooping lily sign, which is an important finding, particularly in pediatric nephrology. So this is a same example where I showed this medialization of the ureter on both sides at L4, L5 level, L5H1 level because of the maiden waist sign, retroperitoneal fibrosis, and which cause proximal dilatation obstruction on both sides. But if you see a same finding only on the right side, that is the left side is normal, but the right side shows medialization and dilatation, then it can be because of the retrocaval. So normally ureter is anterior to the IVC. This is aorta, this is IVC, and this is the ureter. So this is on the posterior side. This is spine, backbone. So this is the IVC and the ureter is retrocaval in location. So this is a abnormal developmental appearance, that is retrocaval ureter, which can be show obstruction like this only on the right side, not on left side. So this I showed you the CT urography or conventional urography showed chelicial cup like this as C-shaped appearance, and you can see the normal angle like this. So this is all this acute angle should be a sign of normalcy. So this C-shaped appearance is a sign of normal chelicial system. But if it is displaced, if it is changed, alteration is there, and you can see multiple dot dot foci, and loss of C-shaped appearance of the calyx. So this is called paintbrush appearance or bucket of flower appearance because of the medullary sponge kidney, because of the contrast retained in the chelicial tubular renal tubules. The normal C is again altered. You can see multiple elongated calyces displaced because of the multiple cysts in the kidneys because of the ADPKD or polycystic kidney disease. This is called spider leg appearance on both sides. So again, as I showed you, this is a corticomedullary phase. You can see the cortex is bright, medulla is dark, so this is normal. But on the left side, you can see abnormal lesions, hypodense, hypoenhancing, significant edema in the adjoining region, and then you can see extension along outside the renal capsule on the anterior aspect because of the pyelonephritis and abscess formation, which is leaking in the anterior space. At times you can see this is the normal infundibulum major calyx, but here it is narrowing because of the tubercular involvement of the calyx. Infundibular stricture is there, and there is proximal dilatation. With time, this leads to putty kidney or complete calcification of the kidney in a late renal TB. So in TB patient, the excretion of contrast is compromised and you see the less density. But in RPN or renal papillary necrosis, there will be change in the shape. The C is all lost and there are different shapes of the calyces, which is all abnormal. So this is because of renal papillary necrosis, but the degree of excretion of contrast is good and opacification is normal, as we can see here. So this Multiple reasons which can be remembered with this mnemonic NSAID can lead to RPN or renal papillary necrosis, which leads to multiple sundry appearances of the calcium system with otherwise preserved excretion of contrast. So this is an important diagnosis which can also be picked up on CT or urography and is an important cause of obstructed system or pain in the renal angle, which can be because of multiple reasons. Then few important points. Whenever there is a lesion in the kidney as seen on CT, if it is a rounded shape, rounded interface between the lesion and the kidney, then it is likely to be a neoplasm. If it is a angular shape or straight margin, then it is likely to be a benign pathology like this, which may be a cyst or a infarct as seen here. Then here you can see a uh, renal tumor on the right side, on the left side as well, and then this is extending into IVC because the RCC is extending into the IVC. Very important is to look at the whenever we talk about the renal tumors are of two types. They can have a ball morphology like this. This is the kidney, and this is a complete ball which tends to deform the kidney. So this is usually a RCC pattern. At times there is a mass lesion, but there is no ball. It is a bean morphology, which which the renal shape, the reniform shape is preserved. So you can see the mass lesion is there, but there is no ball, and the reniform shape of the kidney is still preserved. On with RCC, it is usually deformed. With TCC, it is usually preserved. The shape of the kidney is preserved. So this is bean morphology. This is ball morphology. CT is also useful in predicting the histological variety of a tumor. Like you can see a lesion. This is the aorta. This is the lesion. Compare the enhancement of the lesion with aorta, and accordingly we can decide whether it is a clear cell tumor or a non-clear cell tumor of type of RCC. Like again, this is another example. Hypoenhancing lesion. Compare it with the enhancement of the aorta. If the attenuation ratio on contrast is less than 0.25, that means the lesion is hypoenhancing. If it is hypoenhancing, then it is likely to be a non-clear cell variety of RCC. If it is hyperenhancing like this one, then it is because of the clear cell variety of RCC. So this is histological prediction is also possible in patients with renal tumor. Then there are lot of terminologies related to CT, which is related to post-processing options like MIP. MIP is a post-processing option which combines and generates a 3D image of different pixels. So whenever it is whenever the branching pattern is to be evaluated, the intrarenal vessels in a renal angio, MIP is a better image of maximum intensity projection. This is a form of software algorithm which helps to show the tiny vessels in the renal hilum. But if you want to look at the 3D appearance or three-dimensional picture of a renal vessel in relation to aorta and IVC, then VRT or volume rendered image is another option which helps in. So these are both MIP and VRT are different software algorithms to show images in a CT angiography for kidneys. Like this is a raw image, and this is the 3D reconstruction. This is a raw image, this is a 3D reconstruction. This is along these lines, these are the reconstruction lines, and this is the resultant image. So according to this plane, we can see the complete length of renal artery bifurcation and the hilar branching. Similarly, on the left side, we can see the complete length of the left renal artery and its branch. So this is along a straight line. These are called MPR or multiplanar reconstruction. Similarly, if you want to see the complete length of both sides on in a single image, then you can have a curved plane like this. Previous was a straight plane. So only right side in one image, left side in another image. But here you can see a single curved plane, and you can see the both renal arteries with hilar branching in a single image. This is a curved MPR or curved MPR to show the renal arteries on both sides. So as I told you, calculation of EGFR is very important only on the basis of based on international guidelines of nephrology societies, radiology societies. Now, calculation of EGFR is the basis how you decide whether contrast is safe or not, whether which type of contrast should be given. So only on the basis of serum creatinine we cannot do So it is a standard practice now to use EGFR with several online calculators, which helps in calculation of EGFR. And accordingly, if EGFR is more than 60, then there is a negligible risk of IUD. The MRI and CT contrast so CT are completely different. That is important for you to understand. Uh, the contrast used in CTs are iodinated contrast. They have iodine in them. And in MRI, that is the gadolinium based. So these are completely different compounds. And CT contrast in general has higher risk of nephrotoxicity as compared to gadolinium contrast. So CT contrast are more risky for a patient with borderline TFT values as compared to MRI contrast. So if EGFR is less than 30, then there is a very high risk. And if it is more than 60, then there is a negligible risk of nephrotoxicity with either CT contrast or MRI contrast. So if there is a completely clear evidence of uh, abnormal KFT values and you cannot give CT contrast, you cannot give MRI contrast, then there is an option called contrast enhanced ultrasound. Ultrasound contrast is uh, not excreted through kidneys. That is something important because they are bubble based contrast, air based contrast. They are exhaled through the lungs. So therefore, you need to have a dedicated software on the ultrasound machine. And if there is a focal liver lesion, there is a lesion requirement for contrast study. MRI cannot be done, CT cannot be done. And in that case, ultrasound contrast is a very good option, which is slightly expensive, but is very well possible. And we can evaluate the lesions and their contrast characteristics very clearly without causing any harm to the kidneys because the contrast is excreted not through the kidneys but through the lungs. So these are different indications for intravascular, intracavitary contrast for ultrasound. Like this is an example of a Bosniak category 2 lesion where you can see this is a cystic lesion and the contrast is given and you don't see any enhancing component in the lesion. This is another example where you can see the pseudocapsule in a RCC over time and we can see the peripheral enhancement of the lesion with contrast without any nephrotoxic effect. This is still image where you can see the comparison with the CT image. This is a static image. You can see the this is the arterial phase and this is the arterial phase. You can see the intense enhancement on post contrast ultrasound contrast image. This is brightly enhancing lesion in the liver, and in the venous phase you can see the lesion shows washout. This exactly matches with the CT appearance of the same lesion, where it is hyper enhancing on arterial phase and there is washout of contrast in a delayed phase. So this early washout of contrast suggests that there are tumor neovascularization in the lesion, and that is a sign of leaky capillaries, which is a sign of malignant nature of this lesion. So this is a HCC in a liver, hepatocellular carcinoma in a liver, and because of the KFT we are not normal. So that's why this in such cases it is good to use a ultrasound contrast because it is absolutely safe and can tell us about the nature of this lesion. Another option apart from contrast ultrasound is non-contrast enhanced MR angiography. So CT angiography always require contrast, but MRI it is possible to use to do angiography without the need for contrast. And these are the images of non-contrast MR angiography. You can see the renal vessels, the aorta very nicely, and even up to the segmental branches on both sides. This is the contrast image for renal vascular hypertension, and you can see the stenosis at the ostium, and this part is completely there is signal void because this is a part of stent. So on MRI you cannot evaluate the stent will be completely seen as void on the MRI. Otherwise MRI, non-contrast and contrast are very good modalities for evaluation of the renal vascular structures. This is an example of a patient. uh, so for DSA, what happens in DSA, you will only see the renal vessel lumen. The intraluminal structures are seen. But with CT angiography, you can see the lumen, you can see the wall, you can see the structures outside the wall also. And this is what I was telling, that there is a stent in the right renal artery proximal part. If you do MRI study of this, MR angio for this, you will not be able to evaluate the stent because there is the complete area is dark. You cannot evaluate the patency. But with CT, you can see the stent is there. You can see the distal opacification of the renal artery, and you can see the black line inside the stent. Despite that, the contrast is all flowing, so the stent is patent, but there is some degree of neointimal hyperplasia causing in-stent stenosis in the distal part of the stent. So this is an important thing which can only be picked up on CT and not with MRI. So whenever there is stent, MRI is not the option, CT scan is the option. When it comes to transplant evaluation, there are complete different stages: donor evaluation, recipient evaluation, post-transplant evaluation, baseline, and follow-up studies. So in a transplant patient, the recipient is evaluated in terms of the operative site, whether there is, like in this example, there is polycystic kidney on both sides, there is no space on in the iliac fossa on either sides for the transplant kidney. So this patient would require nephrectomy before a transplant. Otherwise, in this case, there is enough space, but what we can see is a significant atherosclerosis in the iliac vessel. So this is important because direct implantation, direct anastomosis is not easy in this case. So this assessment is required for transplant patients. For the transplant surgical techniques, you are already aware. And coming to the donor evaluation is very important, particularly for a laparoscopic nephrectomy. Nephrectomy for renal harvesting can be open or laparoscopic. So for a open nephrectomy, things are little easier and you don't need to know a lot of vascular details except for renal artery status. But for laparoscopic harvesting, you need to be very clear about the complete details about the vascular pedicle on right side, on left side, arterial pedicle, number of arteries, accessory arteries, and the venous structures as well. So therefore, it is important to accordingly look for the evaluate the renal donor. When it comes to assessment of the renal allograft, it is a complete algorithm, and the most important modality is a ultrasound and color Doppler with spectral Doppler, which evaluates the post-transplant kidney. Elastography is a new technique. Contrast enhanced ultrasound is a new technique which helps in better evaluation of the renal allograft. At times, whenever there is complication, CT may be required for specific indications, but most important next imaging modality after ultrasound is a MRI. So MRI can be done with or without contrast, and a lot of functional MRI applications which I will subsequently mention. But number of transplant complications can be picked up on imaging. So here you can see there is peri-transplant fluid. This is the transplant kidney, and this fluid on aspiration showed increased creatinine values. This is the urinary bladder, and this is the leakage of contrast in the excretory phase, which confirms that this is a urinoma which is leaking into the cavity. So this is another complication. Vascular complications are quite important, and you can see the complete thrombosis in the vein, and we can see the reversal of the blood flow. This is a complete systole and diastole, the velocity waveform. The kidney should always receive blood in all the phases, right from systole to diastole. So this is a Doppler waveform. This is the sample from the renal artery on the right side. The systole में the blood is going towards the kidney, but in the diastole you can see that there is reversal below the baseline. So this is a important sign of renal vein thrombosis, which can be seen on this color Doppler also. This is another example. You can see a anastomotic site aneurysm in the right renal at the site of iliac artery anastomosis with the transplant kidney, and the same thing can be picked up on Doppler and on the evaluated on the CT angiography. This is another example, another anastomotic site aneurysm which was diagnosed on ultrasound Doppler, and then as we could not have given the positive CT contrast, so this is non-contrast MR angiography which was done, which shows peripheral thrombosis in the aneurysm, and we can see the neck of the aneurysm, which is a narrow neck aneurysm at the anastomotic site because of the formation of pseudo aneurysm, and seen without need for any IV contrast with the help of non-contrast MR angiography. Another non-opportunistic infection is very important in these patients, and we can see this echogenic weakly shadowing lesion in a renal pelvis, which is an important differential, that is a fungal ball. So because of the immunocompromised status, it is very common to have fungal ball in a renal transplant in like this, which should be suspected and should be picked up readily. This is another example where we can see the tuberculosis in a transplant kidney. This is another example where malignant transformation is also more uh, at times seen. It can be squamous cell carcinoma, as in this case you can see a focal lesion, focal mass lesion at the site of bladder and the transplant ureter, which is showing intense enhancement in this case. This is another example where you can see the renal hilum is completely lost. You don't see the renal hilum at all because the hilum is completely obliterated by this lesion, and the transplant kidney also shows abnormal enhancement and appearance. This is because of the TCC of the renal allograft. Then multiple other conditions, including vascular conditions like polyarteritis nodosa, can be diagnosed on CT like this. Abnormal appearance. You look at the corticomedullary interface, which is all completely poorly defined. You can see multiple poorly defined areas of abnormal hypotenuse enhancement. This is a small vessel vasculitis of the kidney on both sides, which is because of the PAN or polyarteritis nodosa. More examples like dissection of the aorta. This is the true lumen. This is the false lumen. You can see the kidney is significantly compromised in terms of perfusion because the you can see this is the bright part is the true lumen of the aorta, which has a good pressure head. This has a false lumen which has a poor pressure head, and the renal arteries are arising from the false lumen. That's why there is poor perfusion of the kidneys, and you see the abnormal enhancement of the kidneys on both sides. This is another example where you can see the complete cutoff of the left renal artery. There is complete cutoff the thrombus, and there is shrinkage of the left kidney as compared to the right kidney. This because of the thromboembolic process involving the left renal artery. Then large vessel ischemic process. Uh, then there can be in patients with aortic aneurysm, as in this case, it is important to evaluate the kidneys, the location of the renal artery origin, so that the surgical planning can be done. So this evaluation of the renal arteries on both sides is very well done with the CT angiography, and you can know the exact distance between the proximal part of the aneurysm and the origin of the renal artery. This another example, aortoarteritis involving the renal arteries. Aorta is also involved and the renal arteries are also involved. You can see the three renal arteries on right side, two renal arteries on left side, and all are involved significantly. You can see intimal thickening, irregularity, and therefore there is significant alteration in the renal enhancement on CT. As you can see, the involvement is more in the upper polar region. That's why the atrophic changes are also seen in the upper polar region of the kidneys on both sides. Then fibromuscular dysplasia is an important non-atherosclerotic, non-inflammatory process which shows typical beaded appearance with typical sparing of the proximal part of the renal artery. So this proximal part is spared, mid and distal segments are involved, beaded appearance is seen, which at times is also seen involving the iliac vessels or SMA as well. Then pelvic junction obstruction can be diagnosed very readily, and we can at times see this crossing artery, which is indenting the pelvic junction and is the main culprit, which should be surgically tackled. Otherwise, without the crossing artery, also at times there is pelvic junction obstruction, which may require pyeloplasty depending on the degree of obstruction. Coming to pulmonary edema, because pulmonary edema is very important cause of complication, particularly in CKD patients. You can see bat wing appearance, you can see pseudo tumors like this, entrapped fluid in the pleural. These are the entrapped fluid. This is typically pseudo tumors, so no need to further evaluate. These are typical loculated fluid in the fissure, minor fissure, the major fissure. These are called pseudo tumors because of the fissural effusion. Pneumocystis xerovecii or CME infection. CMV typically looks like this ground glass haze, mainly in the lower lobe region, peripheral GGO or ground glass opacity. And pneumocystis infection typically looks like peribronchovascular cystic changes, interstitial thickening on both sides, as seen in this HRCT image. Halo sign is very important, and reverse halo is very important. In this crescent sign, if it is not dependent, uh, non-dependent, then it is usually fungal ball. If it is crescent sign is dependent, then it can be invasive fungal as well. If there is opacity and significant halo is there, or if there is a reverse halo sign, then both are characteristically seen in fungal lesions, which is very important differential in immunocompromised setting like CKD patients or even post-transplant setting. Tree in bud appearance like multiple nodules are seen, typically sparing the pleural surface. If this kind of lesions are seen with tree-like appearance, tree in bud appearance, then infective bronchiolitis, particularly tubercular etiology, is an important differential. COVID-19 pneumonitis, as you all know, is seen like this ground glass opacities of varying degrees, which can involve both sides. In fungal abscess, tubercular abscess, so this is diffusion weighted images should be known. They are in set of two images ADC. This is flare, this is ADC, this is diffusion. Diffusion may bright and ADC may dark, suggests that this is restricted diffusion and this is because of infarct. This is another example. You can see ring enhancing lesions, restricted diffusion. This is fungal abscess, significant perilesional edema and mass effect. Patient can present with seizures. Another example is press. Press in renal transplant is quite common, often late onset, associated with hypertension and causes less brain edema. So press is a unique pattern of vasogenic brain edema. Usually parieto-occipital posterior distribution is seen and it is typically reversible. You don't see any changes in the diffusion weighted images. This is because it is a reversible thing. You don't see restricted diffusion. This is not infarct. Infarct is irreversible. Press is reversible. And coming to, you are all aware about the CKD patients, the how the kidney, how is the progression of CKD from normal to increased risk to damage and reduced renal functions. The stages are all known to you. But what I want to convey is that right now, from imaging point of view, RI values on Doppler is the most important thing which can be used to decide whether the patient has CKD and what is the CKD progression. Otherwise, but the RI on Doppler has a lot of gray areas. Like you cannot completely rely on RI values because there is a lot of overlap between the normal and CKD stage 1, 2, 3, and 4 patients. So renal biopsy is therefore important and is the only option at times, and you cannot completely rely on RI values on Doppler. But now you should be aware about these new imaging options called functional MR studies, which is non-invasive, no need for IV contrast, and there are multiple imaging tools with MRI, including bold MRI or blood oxygen level dependent MRI, diffusion weighted MRI, diffusion tensor MRI, and ASL phase contrast MRI. These all four options doesn't need any contrast. This contrast enhanced MR rhinography requires contrast. So based on this hypoxia and tissue oxygenation, uh, we have different tools like bold mainly detects interstitial hypoxia in the medulla because it is blood oxygen level dependent sequence. Then loss of peritubular capillaries is detected with rhinography, which looks at the peritubular capillaries, how nicely they are carrying the blood. And third is a diffusion weighted MRI or diffusion tensor imaging, which evaluates the local inflammation and fibrosis in a patient with CKD based on the tissue oxygenation, which is the central key theme for the CKD progression. So these are bold MRI images, and according to the bold MRI values, ROI, or based on the ROI method, or based on the radial profile, based on the fractional hypoxia, you can decide whether what is the likelihood of this patient progressing from CKD stage 1 to CKD stage 2, or whether the cortex and medulla. This can be used in native kidneys as well as in the transplant kidneys. So you can see significant differences between the normal allograft from acute allograft dysfunction or chronic allograft dysfunction in terms of functional MR assessment. So this is completely non-invasive and without any need for contrast, and you need to be at least aware of this because it is going to uh, gradually evolve into an important and robust tool for CKD, and particularly with lot of clinical applications, lot of mm, uh, role in evaluating the drug trials, research studies, and for the surveillance of renal tumor, renal lesions, and in CKD as well as transplant. This is something called as a diffusion tensor MRI, where you can uh, this is something the technique is almost same as the tractography for the brain. So in kidneys there are no tracts but there are nephrons. So these nephrons are all aligned in a particular direction which can be evaluated using this diffusion tensor imaging, and the more aligned that neuronephronal network is a sign of normalcy. With increasing distortion, it correlates with the CKD progression. Like in this example, you can see the normal allograft shows complete radial appearance of the nephrons in this kidney, shown with diffusion tensor MRI. And with increasing renal allograft dysfunction, you can see the abnormal alignment and irregularity and paucity of nephrons in the areas even before things appear on uh, imaging, even routine imaging, T1, T2 weighted images, or on RI, or even before it appears on uh, the functional component, even before it appears as deranged creatinine values. So this is all uh, combined under the condition called under the study called multiparametric functional MRI, something similar to multiparametric MP-MRI of prostate. So this is something called as multiparametric functional MRI of the kidneys, which includes bold and all other imaging studies for native kidneys as well as for the transplant kidney. Quickly, I will go through few radiology spotters, and if the DNB students want, they can write the answer on a chat box also. So what is the answer for this? So you can write the answer on a group chat. So this is a normal kidney on the left side, coronal CT image, and you can see the complete calcific kidney. This is putty kidney because of the old renal tuberculosis. This is not medullary hypercalcinosis because the kidney is small shrunken. This is putty kidney. What is this? So you can see the Doppler image of the right kidney, the Doppler image of the left kidney, and this is the CT urography image of both kidneys in a single image. And you can see there is a lesion here, cystic lesion with fluid level, dark, bright, fluid level, and this is showing contrast opacification. So this is a calacial diverticulum. This is a calacial diverticulum, and on the other side you don't see any opacification here, and you see a peripherally enhancing area in the posterior part of the kidney. This is a renal abscess. So this is a renal abscess on the left side, and there is a calacial diverticulum on the right side in the same patient. What is this? So in a IUP, you need to always follow the complete shape of the kidney. So the shape, upper pole is normal, but the lower pole is poorly defined. Why? And then you can see the lower pole is quite close to each other. This is not reflex. This is horseshoe. Yes, very good. Someone by the name Zara has mentioned horseshoe kidney. This is excellent pickup because you can see the medialization. The lower poles are close to each other, and the axis is also tilted medially. This is horseshoe kidney, and you can see otherwise the ureters are fine. So this is another example where you can see horseshoe as well as polycystic. So this is polycystic horseshoe kidney, which is in fact double problem and can be seen in this particular example. What is this? You can see the abnormal shape of the bladder. So bladder should not usually be trapezoidal shape. This is a elongated bladder, pear-shaped bladder, but surrounding area is dark, surrounding area is bright. So this pear-shaped bladder because of the pelvic lipomatosis. This is pear-shaped bladder because of the pelvic hematoma. Hematoma is hyper, and you will see opacity in the radiograph. So this is pelvic hematoma causing compression of the bladder, and it looks pear-shaped. Here it is pelvic fibrolipomatosis, which causes pear-shaped bladder, and therefore the surrounding area is more lucent. This is another example of a elongated pear-shaped urinary bladder. You can see the abnormal inflamed fat. This is pelvic fibrolipomatosis and causing lot of proximal dilatation and obstruction in the kidneys on both sides. What is this? This is a patient with CKD, and you on a routine scan you can see multiple areas of focal nodularity, focal thickening, seen on MRI, seen on CT, and seen on ultrasound as well. So you can see thinning of the renal parenchyma, small sized kidneys, but the focal area of nodularity is quite thickened. And you can see focal vascularity here. So this is because of the uh, focal nodular compensatory nodular hypertrophy. In transplant kidneys, at times you can see this kind of nodular lesions because of the nodular hypertrophy of the segmental nodular hypertrophy of the kidneys, which is a compensatory phenomena in patient with CKD and should not be confused for tumors, and no need for biopsy in these cases. This is normal right kidney, normal renal hilum. On the left side, you don't see the hilum because the hilum is all effaced. This is called faceless kidney on the left side. So this is a faceless kidney, and the cause is either TB or lymphoma. Whenever there is a faceless kidney, the cause can be TB or lymphoma. What is this? You can see the kidneys are normal, but the left renal vein is dilated in the lateral part and shows significant luminal constriction in the aortomesenteric part. This is SMA, this is aorta, this is the aortomesenteric segment. There is significant constriction. This is because of the nutcracker syndrome. This causes paucity of fat, compression of renal vein, distal dilatation, and it leads to intermittent hematuria. So this is an important cause of hematuria which should be kept in mind. This is again medialization, and you can see the maiden waist sign because of the retroperitoneal fibrosis. You can see the periaortic aorta ke around all. You can see the thickening of the soft tissue which is entrapping the ureter, and there is proximal dilatation on both sides. Moth-eaten nephrogram. You can see multiple areas of poor opacification of the kidney in the DSA image because of the small vessel vasculitis or PAN, polyarteritis nodosa. What is this appearance on CT urography? This is a striated nephrogram. The nephrogram should be uniform, like from uh, upper pole to lower pole, but this is all striated appearance. Striated nephrogram usually is because of acute ureteric obstruction, or because of acute pyelonephritis, or because of acute renal vein thrombosis. So these are important three causes of striated nephrogram: ureteric obstruction, acute pyelonephritis, or acute renal vein thrombosis. This is because of you can see the peripheral, the nephrogram is kind of eaten up, and this is a abnormal nephrogram on both sides because of the cystic renal disease. So otherwise the pelvic system is dilated and shows normal appearance of the calyceal system. What is this? This is all opacification, alveolar opacities on both sides because of the pulmonary edema, which can have varying pattern and can show differential appearances based on the patient position, can be completely seen on one or the other side based on the patient decubitus, and we have different signs on radiograph, different signs on CT, and it is diagnosed pulmonary edema. Multiple nodules in lungs on both sides. If the nodules are similar in size, usually infection. If the nodules are variable in size, then it is usually because of metastasis. So you can see multiple lung metastasis in this patient of long-term CKD because of the metastatic disease from some primary tumor. And variation in size is low, more in the lower lobes, is a sign of lung mets, as we can see here. Okay, this is another example. Normal appearance on left side. On right side, you can see dense persistent nephrogram because of this stone in the right distal ureter here in this example. So when it comes to MRI, this is the important to understand that MRI may vessels look dark because of the normal flow void. So these are renal vessels, renal vessels. This is the right kidney which is normal. On the left side, you can see enlarged edematous appearance and perinephric edema because of the pyelonephritis on left side. On CT, you can see the normal kidney on left side. This is abnormal appearance. Abnormal appearance because of the pyelonephritis on the right side. You can see the obstructed kidney, renal stones, and you can see the air present in the parenchyma because of the emphysematous pyelonephritis in this example. Another example, whenever patient is very sick in a septic state and ultrasound is not able to show the kidney like this. This is the renal fossa. Patient had no surgery, no nephrectomy. Otherwise, patient was all right few days back, and the kidneys are not seen at all despite lot of efforts, and it's very faint renal tissue is seen in an adult age because of the significant air interface in a sick patient. So it should always be suspected that there is some emphysema in the renal parenchyma, or there is something called as renal cortical necrosis. Renal cortical necrosis may, on a contrast MRI, you don't see enhancement of the cortex and medulla, and you see only peripheral rim of capsular enhancement, and there is significant air formation which leads to poor delineation of the renal tissue in a renal fossa on ultrasound. So whenever ultrasound study is finding it difficult to show the renal kidneys in the renal fossa on either sides, on both sides in a particularly sick patient who is febrile in sepsis, always suspect and rule out acute cortical necrosis. So to summarize, as we have seen across modalities, right from X-rays, ultrasound, CT, MRI, and angiography, when it comes to kidneys, when it comes to urinary system, there is a lot of structural details, lot of functional aspects which also can be evaluated at the same time with the help of conventional imaging and with the help of state of the art new imaging options, particularly the functional MRI of the kidneys. So if there are any queries, you can ask.
Kindly share your queries on the chat box, or you can unmute yourselves and ask. If there are no queries, we can thank sir.
Okay, thank you very much.
Thank you so much, sir. Thank you very much for sparing your time and giving us this excellent lecture. Thank you, sir, again.
Thank you. Thank you.